Okay, we are in business, I think. Chapter 30, upper respiratory. Go ahead and give me a reaction or a like or I keep forgetting to put the reactions. Give me a thumbs up when you're down. Cold. Cold. Anybody had the flu? You have one right now. It's my the flu. Anybody have pneumonia? Yeah. I think respiratory can be a little bit more easy to understand because it's something that usually a lot of us have experienced or had people close to us experience in some level. All right, I'm gonna go ahead and start moving through. If you need help with logging in, just let me know. So we're gonna go through upper respiratory disorders. And I think I guys told you last week how I try to keep my husband on track. This week's gonna be kind of a lot of like short little things that I want us to kind of, okay, let's figure these things, like just a little, I want you to know a little bit about it. We're gonna move on. So epistaxis, right? Nosebleed. Some things we call things medically a little bit different, but nosebleed, we need to know how to take care of them. So let's talk about causes. Anybody had a nosebleed in here? Yeah, most of us have had a nosebleed, right? So it can be because we're really dry, maybe you got punched, maybe, you know, who knows, if you have certain medications, right, our patients who are on blood thinners, they might have like a higher rate or incidence of having a nosebleed. So what do we do about it, right? So sometimes you have patients come in to emergency room because they can't stop their bleeding nose. So we got to know, what do we do? So positioning, do you guys remember how do we position them? We actually tilt the head forward. A lot of people want to tilt it back. You're going to tilt the head forward. And then the big thing is apply that direct continuous pressure, right? Because the bleeding is happening in the nose and we're not going to like stuff our finger up their nose, but we are going to pinch the nose and apply that pressure and we're not going to stop. Sometimes we might do ice along the face to try to constrict those blood vessels. Sometimes they do the nasal balloon catheter. If you haven't seen those, they look like tampons and they go up into the nose through your nasal cavity. Your book has a pretty good picture of kind of what those look like. Sometimes in ER, they call them rhino rockets, things like that. But that's only something usually put in an urgent care or emergency, maybe your doctor's office if it's like that ear, nose, throat type thing. Sometimes that might even give you medicine that would cause you to vasoconstrict those vessels. Or they might do some electrocautery, meaning they kind of go in and with cautery, which is like electrical heat, they might essentially stop those veins or like what's that? They cauterize it up. Like what is it? It's like where they, you know, they cut off the blood flow. All right. Moving on, nasal polyps, right? So we talked about bloody noses or epistaxis, nasal polyps. So these often happen with people who have chronic allergies. And we're not talking about allergies to medication, we're talking about seasonal allergies. So that tissue that's inflamed has a more likelihood to develop these polyps or these like growths that happen. So what do we want to do? Well, first, we want to control the allergies, right? If we can help control their seasonal allergies, helps control them developing those polyps. We might have to have surgery, right? They might, because if think about those polyps, if they're growing in your nose, you're going to limit the space that you can breathe in and out of through your nose. We don't want to give aspirin post-op. Why is that? Right? Because it's a blood thinner. We don't want to cause bleeding in that area. All right, moving on. Deviated septum. Anybody had one of those before? Yeah. Do you guys have to have surgery for it? Two? Why'd you have to have two?
Because they took too much septum out when they fixed the deviated septum, so I had to get a rhinoplasty done.
Fun. You have a very expensive face. Yeah. Can I ask, how did you guys, so we'll do one or the other. How did your deviated septum happen?
Well, I was taking allergy pills that weren't working, and then I went into my doctor and he's like, well, just double taking your allergy meds and it should work.
Mhm.
And it wasn't.
Mhm.
So they finally did an MRI and they knew it deviated septum.
Oh, so they don't know what caused it
They
initially?
said they think it was probably an injury.
Mhm. Yeah. Do you know what caused yours? Broken, are you a fighter? No.
3 brothers.
Oh, yeah, yeah. Yeah, so usually with deviated septums, right, like our noses typically are fairly straight down our midline, right? If we get a broken nose or something, right, it kind of shifts that over. But that can cause some problems, right? First of all, your nose, if it's shifted one way or the other, you can't breathe very well through that nose. A lot of times people with deviated septum, you tell them to sniff. Usually the side that it's deviated towards is so kind of closed off that that whole nostril will like cave in. That's really important. We know, like, think about when we learned NG tube insertion, right? We want to make sure somebody doesn't have a deviated septum. If we're trying to put an NG up the side that it's deviated to, it's going to be really closed off. The sinuses aren't going to be able to drain as well from that side. You might notice that they have more sinus infections, particularly on the side where it's deviated to, and they get headaches from that. Don't tell my son, this is not the most flattering picture of him, but he has a deviated septum. Okay, this was a passport picture I took of him this summer. It's such a comical picture, but can you tell how his nose swooped off this way? When he was in 7th grade, he somehow kneed himself in his face and it caused a deviated septum. So hopefully we're gonna get it fixed this year. When they're young, they want you to be usually above 16 before they'll do surgery on these because they need the face to kind of develop a little bit more. My poor son, the like case study for MedSurg in general. Anyway, but I was like, oh, this is a perfect example of what a deviated septum looks like. And when you look at your patients, right, if you're trying to line up, do they have a deviated septum? You can tell where his eyes and then the bow of his lips are, like his nose is like looking the other way, right? That's a pretty good indicator that the septum is deviated. So when you go to put an NG tube in somebody, I want you just to do a little facial symmetry check on them, because that's going to help you see if they have any trauma or anything going on. So what do? Well, usually a nasoseptoplasty or even like a rhinoplasty in some cases as well, because we want to get that straightened back up. Now with that, we want to monitor the vital signs of her bleeding, but we want to report excess swallowing. Why is that? What's the excess swallowing? Right, exactly, because if we think about the septum and the sinuses, if you're bleeding, it usually goes back in your throat. And your patient's going to be swallowing a lot. Maybe they're just swallowing their spit, but that's a sign that they might have some bleeding happening. We want to look at the dressing, and we also want to teach them to avoid activities that increase the pressure. What are things that increase your pressure after surgery with your face? Yeah, bending down, blowing your nose. Fun fact, my mom fell this 2 weeks ago and fractured her orbital bone, and she has all these septum issues as well now. Her doctor told her, don't blow your nose because your eyeball might pop out. And I was like, oh, mom. She was like, oh, no. Her eyeball has not popped out. I think we're in the clear. But right, like we don't think about blowing our nose as being something that can cause injury, but really if we've had trauma there, that can cause some problems. I think I put a picture. Okay, so this is called a mustache dressing. I have a hard time finding a good picture of one, but after any type of nasal surgeries, we want to make sure that people are probably going to bleed. Right? Oftentimes they bleed back into their sinuses down their throat, but they're also probably going to bleed from their nose as well. So we don't want to shove things up there because that's just going to back up the blood and make clotting. So what we do, again, I don't love this picture, but I think it gives you the idea best. Typically after surgery, we just get somebody we give them a surgical mask, right? Real thin one. And instead of putting it on their face, we scrunch it up and just have it under their nose. And then we'll put some 4x4s on it. And that just allows the drainage to go out. You don't want to block up that drainage. And then once that 4x4 gets blood on it, you just toss it and you put in more 4x4s. You want to allow that blood or whatever blood to drain out, but not block up everything. So that's called a mustache dressing, because it kind of looks like a mustache. All right. Okay, here's your first question. And I'm pretty sure you can select all that apply for real this time. What nursing instructions should be provided following a septoplasty? Does it have the answers already on here? It has okay, forget it. Don't even worry about answering. We'll just go over them. All right, so maintain a semi-fowler position. Right, so we want them kind of upright. Take stool softeners. Why do we want to encourage them to take stool softeners? Right, we don't want them to straining to be straight. That can cause that extra pressure on their face. Or we want them to use ice. We already talked about when we don't want them to blow their nose. And then expect a low-grade fever. We really wouldn't, right? A low-grade fever tells us what might be happening. It could be infection. And when we look at surgery, okay, going back to MedSurg1, after surgery, low-grade fever, diminished breath sounds, what are we suspecting? Not infection, but it could be a precursor to it. Adolescence. Remember, when patients don't breathe as well as they should, those little alveoli aren't opening up like we want them to. Patients can start developing a low-grade fever as a response. It's not an infection yet, but we're like, oh, we need to get you breathing better. Okay, moving on. Next one, sinusitis, right? We can use word building for this one. Sinuses, right? And itis, inflammation. So it can be from two different areas. Bacterial, meaning it's an infective disorder, you have an infection. Excuse me. Two, it can be allergic. A lot of times people have allergies and then they get blocked up and that can become infected. So you could have allergic sinusitis that becomes an infection. So signs and symptoms, there's going to be pain and swelling. Anybody had a sinus infection before? Yeah, they're really painful. You have headaches, everything hurts. If you bend over, right, you're like, oh my gosh, my head's going to explode. There's a lot of pressure there. We will probably see fever with these people, right, if it's infected. And then there's probably going to be nasal discharge, right? Therapeutic interventions, saline irrigation. Have you guys seen many of these or anybody do saline irrigations? Yeah, and it's essentially you can buy them like, yeah, exactly. A lot of our ear, nose and throat doctors will order these for patients. And you buy them in Walgreens and there's there's several kinds, some that you kind of squeeze the bottle and it like irrigates saline up into your sinus cavities. There's some like the neti pot that you like, looks like a little teapot and you let it drain in and it drains out the other side. But it's about trying to flush out, first of all, if it's allergic, you're trying to flush out those things that are causing the response for you to be allergic to. If it's infection, we're trying to get rid of any of that bacterial substance from just sitting in there and causing more issue. We might try some decongestants and we'll talk about those in a little bit. Intranasal corticosteroids. Okay, that's a big one. So let's break that bit down. Intranasal, what does that mean? Inside your nose. Yeah, and a corticosteroid. What do you guys know what that is? Right, a type of steroid, right? So do you know like what kind of medicine or a type, like maybe a specific medicine we might be talking about? Fluticasone, yes, yeah, or Flonase is the trade name. That's over the counter. A lot of patients will use that. Remember, steroids are such a powerful medication. And when we take them orally, they go through our whole system, right? There's a lot of side effects that can happen with that. So if it's possible to give steroids to just a local area like our nose, then we don't have all those systemic effects of the steroids. So that's why fluticasone, right? Just in your nose to help inflammation of their sinuses, nasal cavity. So hot packs can be good for these guys, and you can give them some Tylenol, ibuprofen, something to help with the pain and pressure that they're feeling. Okay, now we're gonna play a game. So if you're not logged in, log into the Menti. We've got the code up here, we're gonna play a little game of this or that. So you tell me, which one is it? So if we're looking at symptoms, stuffy nose, headache, and blocked sinus drainage, is that a deviated septum or is that sinusitis? Uh, actually, this one is usually deviated septum because think it's the blocked sinus drainage. That's our clue, right? With sinusitis, you're probably going to have stuffy nose, headache, but it's not blocked that's coming out. Remember the deviated septum, we're shifted over like the poor picture of my son. Please don't tell him I put that up there. Actually, he's in a lot of our pictures, or a lot of my slides. But you know, if it's pushed over to the side of the deviated septum, it's blocking that drainage from coming out. All right, interventions. We've got hot packs, saline irrigation, and positioning. Is that epistaxis or sinusitis? You guys are right. Sinusitis. What's our clue with this one? Yeah, like, I mean, almost, but the hot packs and saline irrigation, right? Because what's the hot pack gonna do? Right? It's gonna vasodilate. If we have somebody that's bleeding, do we want to dilate them much? No. And then the saline irrigation, right? Again, if somebody's bleeding, we want to let that blood clot up. We don't want them to keep bleeding. So those were our clues there. All right, interventions, ibuprofen and acetaminophen. Hey, good job, you guys. Sinusitis is the correct. What's our clue? Right, the ibuprofen can thin your blood, make you more risk of bleeding. We don't want to have our patient with a bloody nose have more, their blood thin more. Okay, what are this one? Our interventions are going to be ice, positioning, and direct pressure. Look how good you guys are. Right, what was our clue there? Yeah, that direct pressure, the positioning too. What position do we hold our heads in? Right, forward, good. Okay, ice packs. Oh, we already asked you guys this. Why do we use ice packs? It's gonna vasoconstrict. I'm not even gonna make you answer this one. You guys are too smart for this. Okay, so now I want to talk a little bit about obstructive sleep apnea, because you guys are going to see this a lot in our patient population that we're taking care of. It doesn't matter if you end up in a doctor's office, in urgent care, in long-term care, acute care, people have obstructive sleep apnea. And I think a big part of this is if we can help patients to either get diagnosed, to be compliant with their treatment, to whatever it is, to help them to actually treat it, they're going to have a longer, healthier life. So that's, I think it's important, especially in our community. I think I have a video here. Okay, so I want you guys to look. So apnea during sleep. You don't have to tell me you have sleep apnea. Does anybody have a partner with sleep apnea? Yeah, what does that sound like? They kind of stop breathing, right? Usually they're breathing and it's kind of, sometimes they're snoring, they're loud and they're and they make these kind of funny noises and then they kind of stop and they're like trying to breathe, and then they, after however long, they take these deep breaths. In the video you kind of see what's happening. The risk factor is a lot of times if there's obesity, if there's extra tissue around here, around your neck and throat, high palate or reduced mandible, and that's how things are kind of situated in your mouth. Also smoking, because of what it does to our lungs and everything else, it does make you a higher risk. So it's a pretty short video, but I want you especially to see when it shows you what happens, like physiologically, what that does to people when they're sleeping. You guys hear okay?
No, I can't hear it.
Okay, so that's more of like at the end, it's more of a commercial, but I really like that video because it shows us not only some of the physiological things that happen, but it also talked about the prevalence of it, the risk factors, the symptoms. What are some things that stood out to you about some of the information? Undiagnosed, yeah. Anybody else? It affects so many people, yeah. Yep, men are more likely. Do you guys remember those lists of symptoms that people have? Fatigue, depression. Yeah, they can't concentrate, they're not off during the day. A lot of times these people, their quality of life is pretty low. Not low, but it's not as good as it could be, right? I have a friend who's not much older than me that was diagnosed with sleep apnea, and she's a nurse. And she was like, ugh, I do not want to wear this CPAP. It's horrible. Like, and just like this video was saying, she saw her primary doctor. She was sent to a specialist. They did what's called a sleep study, and they monitor you and they see, how many times per hour you stop breathing, for how long. They monitor your oxygen saturation. When you stop breathing, your oxygen saturation drops, right? You don't have enough oxygen in your blood, and you can't fuel all of your, organs. So anyway, she went to her specialist, she was diagnosed, and I talked to her, she was like, this is horrible, I hate wearing this thing, it's miserable. And I was like, hey, that's rough. A couple of weeks later, I checked in with her, I'm like, how's it going? She goes, oh my gosh, they got me a different mask, I got fitted better. She goes, I actually sleep now. She goes, I didn't realize before, I wasn't really sleeping. And during the day, like, energy, I can focus on tasks, I can do what I need to do. Like, she thought she was living a good life. And then after having the treatment, she was like, oh, never again. I'm never going back to not. And so, not that that's everybody's story, right? Not everybody is so profoundly impacted, but I found that most patients, they can tell you if they don't wear their CPAP when they're supposed to, they feel it. They have a hard time, a hard day. A lot of them, a lot of patients don't want to go get treatment for it. I've seen a lot of resistance with patients. They're like, it's fine, I'm just not sleeping well, I'm tired, and they can give all these excuses. But one thing I want us to remember is that undiagnosed and untreated sleep apnea it's not just a quality of life. It really puts a stress on your body. So if you have sleep apnea that's not diagnosed, it's not being treated, you are more likely to have hypertension or worsening hypertension, diabetes, high cholesterol, all of these things that are really hard on our bodies, right? You have increased risk of those. And so that's what I try to tell my patients. It's like, really though, it might seem like it's just making you more tired. It's really contributing a lot to your body. It's making your body work a lot harder than it needs to. And sometimes I want to encourage you to encourage your patients to talk about what type of mask to wear. I feel like I put on here. Here's like a typical type of CPAP mask that you see, kind of covering the whole face. Some people, especially if they have claustrophobia, they really struggle wearing this. So there's other options like, I thought this picture was so funny. This guy, like, he's young, he's on his phone, like he's not even sleeping. Like, but so it just cracked me up. But you can see it's just the nasal piece, right? Or sometimes they can have like a little triangle that just goes over the nose. So depending on people's facial structure, how they breathe, right? If they're a mouth breather, they're probably going to need something that goes over their mouth. But if they just breathe through their nose, they might just need a piece that covers the nose. So we really encourage them to work with your provider. See like what kind of facial piece or like how to adjust it. Sometimes I'll put different like padding on the face to help, because sometimes you have to have a good seal on whatever it is so that it gives pressure. That pressure or the CPAP, that helps to hold that space open. Like you saw in the picture where kind of all that palate kind of relaxed down and cause compression. That extra pressure with the CPAP helps to hold that open a little bit so they can keep breathing. Great question. So I've had a lot of patients that I've seen who lose weight and it goes away because it's that weight that's causing the problem. There are some surgical things they can do. Those are pretty, like, that's more invasive. So sometimes we try to say, hey, less invasive. If you wear your CPAP, that's not very risky. Surgery could be risky. Sometimes we tell patients to, oh, what are those strips like athletes wear and stuff to like open up their noses? Sometimes patients can wear those and that can help to just open up the flow enough to help treat that. But yeah, typically the only time I see it go away is if it's something like weight loss or surgery. Oh, that's a really good question. I don't know. If you didn't hear, the question was if you stop smoking, would it go away? I'm not really sure. I'll have to look that up. Okay, going back. So we talked about some of these complications, signs and symptoms. So the diagnostic tests are we talked the polysomnography, that's a sleep study. And then treatments, right? We also, I didn't talk about, but avoiding sedatives, right? These patients are really out, like they're struggling. If they have alcohol, if they're taking things like medications to make them even more sedated, they're less likely to be able to rouse and start breathing again. So we want to try to avoid the sedatives for them. Okay, all right. So I love that we have little like partner desks here. So we're gonna do a little activity cue. So put yourself in the shoes of you are the nurse. You're at a long-term care facility taking care of a patient recovering from COVID-19. This morning, he's short of breath with an oxygen saturation of 87% on room air. So turn to the person at your table or somebody around you and let's talk about what do you do? All right, who wants to share? What did you guys come up with? Set them up, yeah. Oxygen, yeah, per protocol. You guys know what I mean when I say per protocol? Ish. Most facilities, long-term care, acute care, wherever you are, they'll have protocols for nurses to put on oxygen or to do something, right? Because oxygen is a medication, right? It requires a provider order. But most places will have a protocol that says, if a nurse using her assessment skills sees something that happens, right? Low oxygen, they can put on oxygen, usually up to a certain amount. And it also usually will specify, and you need to go notify the provider, right? So that we are, but it's so you don't delay your care, right? If the patient needs oxygen, we want to put them on oxygen, but we also want to make sure we get the order for them. Okay, so yes, sit them up, put on oxygen. Anything else we want to do? Encourage them for deep breaths. Are we going to do anything else? Right, yeah, we also want to kind of push this up to the provider and say, hey, you know, what's going on with this person? I think our Davis people said, oh, wow, I keep forgetting when I ask you those questions. So get ahead of the bed up, start oxygen. You might need to transfer to a facility, right? They might need to go to acute care. Encouragement and emotional support. I think that's something we forget to verbalize. I think most of us will do that, right? As we're getting them sitting up, as we're putting on oxygen, we're kind of saying things like, hey, we're here with you. We're going to help get this better. You know, but we're going to take care of you. We're giving those things to help him be encouraged, right? Because we don't forget about Maslow's, right? We want to make sure that the patient isn't just a room number that we're treating like robots, right? Like we're actually looking for them, we're caring about them. Okay, so I know we've gone kind of quick through this. How are you guys doing? Lost? We got it? In the middle somewhere? In the middle? Mm-hmm. You got it. Oh. Okay, everybody's doing okay from what I see so far. Good, because I know we went through pretty fast, but like I said before, a lot of the stuff we're covering is things that we're more familiar with. It's a little bit easier to relate to. All right, so now let's talk about infectious disorders. What we were talking about before is more structural issues, a little bit of infectious, but now strictly infectious stuff. So you guys did a chart over for your homework that was influenza versus viral virus. Excuse me. So we're not going to go super in depth because I know you guys already did work on this. Infectious disorders, viral rhinitis, common cold, right? Kind of a long, fancy term. But remember, like rhine, like that prefix, that's more talking about the nose. So like rhinoplasty, like that's the surgery to kind of fix, straighten up our nose. Pharyngitis, these are all just like inflammations, infections of the different structures, right? It's an infection or inflammation of our pharynx. A lot of times it's from some sort of strep infection. So strep throat, right? Most of us have had strep throat or have kids who've had it. What are a lot of the signs and symptoms of viral pharyngitis? There might be discoloration. It's really painful to swallow, right? So a lot of us have seen this before. Laryngitis. What's the larynx? Right, like how you speak through, right? So inflammation of the mucous membrane of the larynx. What could cause that? It could be straining your voice. Yeah, it could be a cold or sickness. It could be a variety of reasons, right? Sometimes after I teach on the days where I'm talking a lot, sometimes I'm like, oh, I've got a little bit of laryngitis. My voice is a little bit, my larynx is a little bit irritated and I want to go drink some tea. Tonsillitis, infection of the tonsils, right? A lot of times when we talk about tonsils, we also look at the adenoids. which are on the sides there. And so oftentimes, if people have to have surgery of the tonsils, they have to also remove the adenoids as well. Okay, so rhinitis, that can be either viral or bacterial or caused by allergies, right? So that's why it's kind of hard when, like, we say, like, your rhinitis, like, you want to ask patients, do you have a cold? Like, is it infection or is it just allergies? The viral rhinitis, that's the common cold. What are some things that might differentiate between allergies and a cold? Yeah, like some context clues, like what are other symptoms they have? I like what you said, Alexandria, about seasonal, right? If it happens the same time every year, it might be something around you that's blooming or giving off pollen that's causing that issue. Common cold symptoms, it's usually a slow onset, right? So when you get a cold, and it happens gradually over a few days. You can have a low grade fever, but usually it's low grade fever or no fever at all most of the time. Runny nose, sore throat, and oftentimes you have a cough. So cough with a cold. So treatments, rest, hydration, and then you don't want to spread infection. How do we keep from spreading that infection? Right? Wash your hands. That's one of the bigger ones, yes. Influenza. A lot of people, this maybe is like a personal preference, but people will talk about, like, I've got the stomach flu. I'm like, there's no such thing as stomach flu. Because when we say flu, it's influenza. That's what we're referring to. And that is a respiratory infection. Now, if you have a stomach bug or something that, gastrointestinal issue, you can call it a stomach flu, but it's not the flu. Just want to put that across the board, because a lot of patients too, they'll say, oh, I think I got the flu. And you're like, oh, well, maybe they've got, influenza. We're gonna work them up. They come in, well, they've been having diarrhea. So, right, so I think it's good to know, like, we don't want to assume that people are using the right terminology, and then you guys are going to use the terminology too, so we know. So flu, influenza, that's respiratory, not digestive. All right, so transmitted by coughing and sneezing. So how do we prevent it? Just like you guys said, yearly or hand washing. There's flu vaccinations. Flu vaccinations are so interesting. They change year to year. Like the flu vaccine you got this year is not the same as the flu vaccine you got last year. There's scientists, there's doctors and nurse researchers who look and they say, what are the most common types of flu virus that we predict to see in this area? Because the flu vaccine that you guys get or we get here is different than what they give in Texas or New York or anywhere else. They predict in your specific area. We usually follow the continent that starts with an A, and it's not Africa, not Asia, Australia. I don't know why I'm blanking on that name. We usually follow Australia with our flu virus that we typically have up here in the Northwest. I don't know why, but it's just kind of interesting. So it's important to let people know and educate them about vaccination, that it's not, oh, I had it last year, I'm fine this year. It's every year, because viruses are so intelligent, right? They change, they adapt, they morph, they turn into something else. While we're talking about vaccination, let's talk just for a minute about, in general, when you get a vaccination, does it work right away? You guys know how long it takes before you generally have that resistance to whatever you're getting vaccinated against? It's usually a couple of weeks, usually about 2 weeks for your body and your immune system to mount that defense, to take those particles and be able to say, hey, now I know how to defend against it. In the meantime, if you're introduced to maybe the flu virus, could you get sick? Absolutely. What about your symptoms? Like when you have a vaccine, you are stimulating your immune system. What does that feel like? kind of feels like you started to get sick, right? Because your body is building resistance to, well, let's use the flu as an example, right? You might feel tired, you might feel fatigued. Sometimes people feel like a scratchy throat. I hear so many people say, I don't want to get the flu vaccine because it gives me the flu every time I get it. And when reality, what's probably happening is either one, they're having symptoms of their body, building immunity to the flu, or two, maybe they actually get the flu, but if they're exposed to flu virus in that first 2 weeks, their body hasn't been able to really mount a defense against it. So I think it's a good opportunity to provide education to our patients about, really this is to help you prevent you from getting sick. And this is kind of how the vaccine works. I think as nurses, we are the ones who really get to talk to our patients about this. We get to have like relationship. You can have all these campaigns, but if people don't understand, they won't get the vaccine. Okay, and also we want to avoid infected people, right? If you have influenza, you probably should be staying home, right? We want to spread that to our community. All right, so if we talk about complications of influenza, which patient, me, how did it not reset? Oh, okay, the answer is already there. Why is the correct answer the 78-year-old retiree? The age, right? As we get older, we lose some of our immune system functions. We're more prone to getting infection. So he is the most at risk. All right, so signs and symptoms: fever, chill, myalgia. What does myalgia mean? Yeah, muscle pains, body aches, sore throat, cough, malaise, headache. We're going to give them acetaminophen. We're not going to give aspirin. They might get antiviral agents. Anybody had the flu and gotten the antiviral agents? Usually it's I don't know what some of the names are for them. Tamiflu, yeah, it's a real common one. Anybody ever get that? Yeah, the big thing with Tamiflu, a lot of times they want to focus on giving it to older people or more risk people. So maybe if you have asthma or other lung diseases. And to get the Tamiflu, you have to be within a window of first having symptoms. Usually it's within several days of first having symptoms, because that's when the Tamiflu is going to be able to stop some of that virus replication in your body. Once you've gone beyond several days, your body's going to play it out. Like it's just you're going to get better eventually, but the Tamiflu is not going to be as effective because you've already just been a fabulous host to that virus and allowed it to grow a lot. So the Tamiflu is not as effective. Okay. Other respiratory infections. I don't know if you guys remember West Nile from a while ago. I was in ICU, working in ICU when that was a big thing and everybody was really worried about it. COVID-19, right? Or there's bird flu, SARS. Well, we'll talk about SARS later. And then swine flu, right? So we see all of these viruses, like if you're in healthcare long enough, you're going to see a bunch of, especially these viral infections that just, they mutate, they transfer, and we, as humans, will get them. And then usually we form resistance to them, or we have like with influenza, it's kind of stuck around a really long time. And that's why we've developed some viruses or anti vaccines, thank you, to help. I didn't get to finish drinking my coffee today, so I think I'm needing it. Okay, we're almost done with this, then we'll take our break. Oh, good Lord. Okay, for a sore throat, why is salt water the right answer? You always just do it, you just know. but it's a good therapeutic intervention, right? Why do we put salt in the water? Yeah, it makes it more of an isotonic solution, right? It makes it more what might draw out a little bit of that fluids and things. Okay. This or that. Let's play another game. What do you think? So if we're talking about the common cold or influenza, slow onset. Which one has a slow onset? Oh, good job, you guys. Yes, the common cold. Influenza usually does kind of happen. You're like, you're okay one day, and then by that night, you're like, I am in the bed, not feeling well. Will benefit from rest and fluids. This one was kind of tricky. It's both. Both influenza and the common cold will benefit from rest and fluids. Fevers are more common. Yeah, influenza. With the common cold, we typically don't see a fever. Or it's low grade. Headaches are common. It's both. Influenza, a lot of times they have headaches, but it's a general headache. Where a common cold, it's a headache because they usually have sinus drainage and that sinus pressure is causing the headache. So that could be a diagnostic tool we use, right? They're like, oh, I have a headache. I'm like, well, tell me about it, right? If it's like, I don't know, I'm just pounding up here, you know, just it hurts just all over, it's vague, or if it's really the sinuses that are causing the issue, that helps you know, cold or flu. What about a cough? It can be both. I would say usually I see it more in a cold is more when you have somebody coughing a lot, but you can cough with the flu as well. Sore throat. It's usually more with the cold. I think occasionally with the flu, you can have sore throat, like anytime we're coughing or have any drainage that can cause sore throat, but usually I think sore throat with the cold because of all that drainage, right? If we have a lot of sinus drainage, it's kind of dripping down the back of our throat. That's irritating and that makes our throat sore. They can have antiviral medications. Yeah, influenza. For the cold, it's generally less serious. We don't need to have antiviral for the cold. People can recover pretty easily from it. What about muscle aches? What's the medical term for muscle ache? Myalgia. Yeah. Good job, you guys. Influenza. We talked about those already. Nursing diagnoses, as you guys are in clinicals, you know, we're going to start looking at some of these nursing diagnoses: impaired comfort, hyperthermia, risk for infection or transmission to others. Some medications. You know what? Let's just take a break and let's come back to medications after that. Yeah, so let's do, what time do we have over here? The clocks are different. Let's do about 15 minutes and come back at 25 after. Okay. Um, I think that you have a big issue with medications in general. We talked about cold and flu medications specifically. Well, let me click back into the screen here. Okay. So this was from actually last year when my husband had a cold and he asked me to get more medicine. And I want you guys to know, like, if you look at these two medications, they look very different. Right? Right? Like he was like, yeah. And I think if I remember what happened is we ran out of the one on the right. And so he went to go pick up the other. He's like, oh, I need more of that cough medicine. And so he picked up the one on the left. The one on the left has quite a few more, or did I say that right? The one on the right over here. Oh. So I took another picture. This one here contains all of these medicines in this one medicine. The severe cold and flu has dextromorphin, cough suppressant, has acetaminophen, it has phenylephrine or Sudafed, and it has guaifenesin. So my husband unknowingly was about to double up on all of his cold medicine. Right? That's why, most of the, I don't know if you guys have noticed in the last decade, maybe, you guys are so young. There have been a lot of warnings on medications about don't take like other medicines at the same time, because you can see how if somebody's at the store, like these look so similar, right? You really have to read the labels. And so that's why a lot of companies, or actually I don't know companies, but I think a lot of the medical world is trying to move people away from these mixed medication pieces here, because first of all, Tylenol, we know if we overdose on Tylenol, if we take too much, what is the main thing it damages? It damages our liver, right? These other medicines, we take too much of them, they can also have some negative side effects. And if patients aren't medically savvy, or if they're just sick and they're coughing and their eyes are watering, they might not be able to read as well. We want to make sure we give them good education of look at your bottles, look at what's in them. Because how easy would it be for somebody to say, oh, I've got my cold medicine, but hey, this one helps with congestion and this one helps with the cough. I want some Tylenol because my head still hurts. And then I want to, this looks like it's supposed to help me cough up stuff, right? Like you could be taking so much more or double what you really need to. So it's important that we know, make sure our patients are aware, right? You're gonna go home today and like be looking in your cupboard, like what's there, what's really inside these cold medicines. So cough suppressants, dextromethorphan. I want you guys to add that to the bottom of your medication list. When we do, we're gonna actually do our medication like dice game next week, but we're gonna include this one on there. So it's a cough suppressant, excuse me. It works on our central nerve system. It's actually suppressing part of that, the center in the brain that stimulates those coughs. Oh, we don't want to give it under children years old. We don't want to give it to young children. What's something, thinking about how it's working on the cough center of the brain, what's something we should think about? Like we want to maybe avoid in certain other populations. So knowing that it works on the cough center of the brain, so it's working on our central nervous system. All right, look, so somebody maybe needs a cough, or maybe somebody who already has neurological depression, if they're already kind of sedated, we don't want to give this to them because it's going to cause more sedation, possibly. And then we just don't give it to kids. Okay, everybody have time to write this down? I'll wait a little bit longer. When you guys are looking up medications, like when I give you the tables, those medicines, I believe they should all be in your book. And in the book, they usually have really good tables that kind of show you as like a medication that's a good example medication, the nursing interventions. You can look at your Davis drug guide as well. But really, I think your books, as far as like learning for this class, being prepared for the test, the medication tables in the books are what's going to really help you be the most prepared. All right, so moving on, next medicine, nasal decongestants. So phenylephrine or Sudafed. This medicine works by causing vasoconstriction in the sinuses. Because it causes that vasoconstriction, we want to make sure we're cautious. We're giving it to patients who have high blood pressure and other cardiac diseases. Causes vasoconstriction in the sinuses. Gonna help to open up some more space. Causes that vasoconstriction. It's not limited to just constriction in the sinuses. It can cause a little bit of vasoconstriction in the rest of our body. What does constriction do to our blood pressure? It causes it to go up. So if somebody has high blood pressure, we're probably not going to have them take this because it's going to make their blood pressure go higher. Again, I don't like those bottled medications because it's really, they have, because there's so many medicines in there, there's so many warnings and things, they really, it's easy to get missed in those. Expectorants. Anybody seen the Mucinex commercials with the green globby guy? It's so gross. But guaifenesin or Mucinex is a good example. It helps to thin and loosen the secretions in your airway and lungs. Encourage patients to drink a lot of fluids because if those secretions are getting dried out and hard, it's really hard to, even if we're loosening them and the medicine's working on thinning them, it's having to work even harder to get them out, and it's usually more painful. No, it's probably just gonna harden the secretions. So looking at an expectorant, what it does, do you see any relationship of how the cough suppressants might affect that, or how they might interact with each other, or why they could cause conflict almost? Right, because the expectorants, that's with people who have things in their airway, they're coughing up mucus. We want to thin it out, we want to get it loosened so they can cough it out. We're giving it at the same time as a cough suppressant, we're actually diminishing their urge to cough. Another reason I don't like, I'm going to give you so many reasons I don't like the combined medicine. But my suggestion to patients is when you wake up, yeah, take a Mucinex, take a warm shower, all the steam as you breathe that in, that also can help to loosen up all those things. Let's get out. We don't want to depress our cough right now. We want to get all that stuff out. And then later you got to go to, well, hopefully you don't have to go to work, right? We don't spread it around, but later in the morning, you've got that good stuff, hopefully coughed out a little bit, then take a cough suppressant if it's really irritating. Or take your cough suppressant at night when it's keeping you awake, right? I don't care if you're not coughing up the mucus during the nighttime. I don't want you to sleep. Take that cough suppressant, but take it usually like not at the same time as you're taking the expectorants that you're trying to get it out. Does that kind of make sense? How we don't necessarily want to get them together. So it's like, okay, here's your expectorant stuff to help loosen up all this mucus and get it out, but I'm also going to stop you from coughing to get it out. It's better to give it at different times. All right, I have one more on here. I don't. Okay. So you've got those medicines on there. I didn't have them on last time. And I think they're really important to know because those, like when you see patients, those are going to be some of the biggest medicines your patients are going to be taking over the counter in the fall time because people get cold or they get the cold, they get flu, they get something where they don't feel good. And so they start taking all these medicines. So moving on, cancer of the larynx, right? Every system, we kind of usually talk about cancers. So usually there's a tumor in your nasal tissues, and it can metastasize. You guys know what metastasize means? Yeah, it spreads out. Oftentimes to the lungs, right? That makes sense. It's in our nose. Those cells could easily travel down to the lungs. Might go liver or lymph nodes. Anytime you have a cancer, there's usually common spots that it will travel to. You guys don't have to memorize all that, but it's good to know when you're working that, hey, if somebody gets diagnosed with a certain type of cancer, based on where that cancer usually metastasizes to or travel, that lets them know where to look to see if it has traveled. So usually it's associated with smoking and alcohol and more common in men. Sorry, guys, that's just your lot in life. We have periods and babies and we have more cancer. I'm sorry, I won't go any further with that one. So signs and symptoms. So remember our larynx, like our laryngitis, right? It's irritation there. So one of the biggest first symptoms is going to be a sore throat or like hoarseness of the voice. Like where you're not, man, my voice just sounds different. I'm not speaking the same. They might have some pain, but usually it's a little bit of cough. They might have some trouble swallowing. It's kind of vague symptoms, really. They're gonna do a laryngoscopy to look in, where they just go in with a scope and look at the larynx. They're probably gonna do a CT scan and an MRI to kind of get a better picture of what they see. You can see here is somebody who had a laryngectomy. So usually for these people, they'll do chemotherapy, they might do targeted radiation at that cancer site. But a lot of times they have to remove the larynx, right? And so this is where we'll see people that now they'll have a tube where you breathe through their throat. So that's where they have, like, have you guys taken care of tracheostomies in lab yet? Yes, this is where people will have tracheostomies, right? Sometimes if somebody has had, especially if it's not an airway issue, if it's not a breathing issue that caused, their need for a tracheostomy, these people, it's not the breathing that was a problem, it was an obstruction and cancer that was the issue. More often with these guys, they're not gonna have like a tube and things. Sometimes you might just see them with just that hole, like once it's well established, because they're breathing just fine. They don't need any support with that. It's just that the regular pathway has been blocked. With these people, nursing diagnosis, right? Like pain, impaired nutrition, right? They're gonna have to have their issues with swallowing. Most of them, it damages their esophagus as well. A lot of them have to have tube feeding. Disturbed body image. Oh, good Lord. Oh, I gotta figure out how to reset these slides the right way. So common risk factors, alcohol abuse, and then diet low in fruits and vegetables, right? A lot of times what we're seeing is patients who don't get enough natural fiber in their diet with those fruits and vegetables and the nutrients that comes with that. All of our good vitamins, they are more at risk of cancer. So here's some for those people, right? If you have a tracheostomy, it's more difficult to speak. And so they have there's this little machine that can go underneath your tongue, and that helps to project sound if you're able to still push air upward. There's also these things that go, I don't understand how it works, but it diverts air, essentially goes back into your esophagus so they can push it back out the vocal cords if you have some that are working. Have you guys seen where the people have a little box and they hold it up here and talk like that, right? Like that's another device that people use. But communication for people who have cancer of the larynx, that's a big issue for them being able to communicate. All right, so case study. I'll go back to this screen. Mr. Gray is a 90-year-old resident of a long-term care facility. He's usually alert and oriented with a joke when you come in with his medications. So you're the nurse, you're coming in for his medications for him. This morning he's confused, and you note that he hasn't been touched his breakfast. You asked assistant personnel to collect a full set of vital signs. We've got a blood pressure of 110/84, RESP's at 24, pulse is 104. Oh, 4 is there. Temperature is 100.9, and you note that his mucous membranes are dry, He was reporting a headache and he refuses to remove his winter jacket because he feels too cold. Lung sounds are clear. You're preparing to call the healthcare provider regarding his condition. Think about the information you should include in the phone call. Turn to your neighbor or group and communicate using the IS bar. Afterwards, we're going to review. So you guys remember the steps of the IS bar? So I is introduce, situation, background, assessment, recommendations. I think like repeat back, like if they order something, like right if the provider gives you an order, you want to repeat that back or read it back. Okay, I'm gonna go back to this screen. Okay, so take a minute, formulate what your IS bar would be, and then practice saying it back and forth to each other. All right, so let's see what FA Davis recommends and see if it matches up what you guys said. So I identify your name and your title, right? You are the nurse. Situation, Mr. Gray is a 90-year-old resident of long-term care who's a full code. Background, they didn't really tell you his background, so right, you're not wrong for not making it up. But if we knew, we would say, hey, no allergies, history of hypertension, hypothyroidism. We could say, usually he's alert, he's awake, he's got a good appetite, he's funny. And then he's got new confusion and a poor appetite. We tell him the vital signs, lungs are clear, mucous membranes are dry, he reports a headache. Recommendation, I'd like to start him on some IV fluids and complete a rapid influenza to see if he benefit from an antiviral medication. Anybody get that part, IV fluids or flu test? Flu, you got the flu, good, right? And that's gonna be with time, and I don't know if I'd start him on IV fluids right away, but we already know mucous membranes are dry, he's not wanting to eat or drink, and so he's already probably a bit dehydrated, he probably would benefit from some IV fluids. But yes, the rapid influenza, and especially because his symptoms just started, if he is positive, he's within our window of taking those antiviral medications that would help him get better. And the less virus that he produces in his system, the less chance, that's the less virus that's gonna be able to spread through his long-term care facility. And then read back, repeat back, we would restate the message. I don't want to do the concept one. What I am gonna do is have you guys split into some groups. So the bag of equity will choose which groups that we are in today. And we're gonna do a little case study about a patient with the flu. I know we're kind of hitting on that a lot, but guys, we talk about respiratory stuff. The most common things you guys are gonna see are colds and flus. So we don't know, I'm not. No, I got that. She got it. You know, it seems kind of silly that we break out every week. So actually, this is a really good question. So one thing I want you guys to remember in class, if you have questions, you are probably not the only one who has that question. So please ask. So the question that was asked was, if there's protocols for oxygen, when we can give it, are there also protocols for like Mr. Who wasn't Adam, the other guy that we have? Could we give him some feedbacks without waiting for the doctor's order? And the answer is not necessarily the protocol, right? But there has to be protocols in place. Often we pick a special one because we do want to make sure. Oh, yeah, everybody have a, sorry, I forgot. Yeah, most places want to have a protocol in place for oxygen because we don't want to delay airway breathing, all of that, right? Long-term care facilities, they're really good about when somebody is admitted, that they're like, listen, we're gonna have something PRN for pain, PRN for fever, PRN for nausea, PRN for constipation, like anything you could possibly have an issue with, those providers usually add an asthma medication. You guys are in acute care right now for your clinicals, right? The hospital does that to some degree, but when you guys start having long-term care rotations, you're gonna look at these patients' medication list, and you're like, oh my gosh, there's like 20 PRNs on here. And that's with purpose, because they know that their patients are gonna encounter some issues, right? And these patients aren't acutely ill. Normally, if they were home, they'd have to go to the pharmacy and buy whatever they need. So it's, when people are in the hospital, a lot of times we do wanna call our providers and get an order, because it might interact with what's going on. They are more acutely ill. They're more concerned with what's happening with them. In long-term care, those patients are usually more stable, so they can't order all of these PRN medications, but they have to be ordered before we give them. So those are really good questions. So please don't worry about asking questions. So here is the, oh, I think I printed. Oh, actually, find your groups. Yeah, find your people. I'll pull up the case study. So our case study, we have a 32-year-old mother of 3 children between the ages of 3 and 10. She's diagnosed with influenza. Her 10-year-old child has an autoimmune condition treated with glucocorticoids, excuse me. She's a single mother who lives with her mother, who is 68 years old. The patient does not require hospitalization. So it's a little bit complicated, right? We've got 3 generations of people. Sounds like 2 of them might be kind of have some immune issues. So the first question, what patient teaching is a priority to prevent the virus from spreading? 2, which symptoms should the patient report to the healthcare provider? 3, what medication teaching should the nurse provide? 4, are there any dietary instructions the nurse should provide? And then the last one, I'm going to say it's number 5, are there any recommendations the nurse should make for the rest of the family? So when you're looking at this, if you have questions, I strongly suggest look at your Davis book. They have boxes and like the answers are all in your book. So take a few minutes, and once we kind of all have, we're gonna all answer all the questions, and then we'll kind of go group by group to answer each one, and we'll review. All right, so, oh, my God. That's problematic. Okay, we'll wait for that to kind of get started. So how about group in the middle? Are you guys the circles? Yellow circles? What is a patient teaching, or what patient teaching is a priority to prevent virus from spreading to family members?
Exposure. Or high risk.
Yeah, anybody have anything different, similar? Yeah.
Try not to touch your mouth, nose, and eyes.
Yeah, right, that's so hard. Anybody else have anything adding on? Right? Yeah, disinfect. Like when anybody in my family gets sick, I have a little thing of Clorox wipes. And I just like give everybody, I'm like, just go get all the door handles, get anything that we touch a lot. Yeah. In the back, number 2, which symptoms should the patient report to healthcare provider? Malaysia? Mm-hmm. Anybody have anything different or everybody kind of the same? Oh, yeah. Yeah, good one, right? Because that might tell us about oxygenation. Excuse me, far back. What would you guys say about medication teaching that we should provide? Right, right. Mm-hmm. Mm-hmm. Yeah, that's great. I like that you guys included the flu vaccine, right? Kind of checking on that because it's not going to help prevent the grandma or this, I think it was a son, from getting the flu, but really encouraging them, like, do they understand that can help prevent them or help protect them? Excuse me. Anybody else have anything else to contribute? From you can't get sick from the vaccination. Yeah, yeah, yeah. Just educating them with that. Mhm. 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 Right. Yeah, finish your medications. Fahim, what were you gonna say? Mhm. Right, right, because sometimes patients will say, well, I'm sick, I want antibiotics. And if it's a viral infection, they don't need antibiotics. There can be times when patients have a viral infection and you can get what's called a secondary bacterial infection, meaning you're sick with a virus, like maybe you have a cold, and then you're getting your sinuses are all plugged, you're kind of sick. Well, some bacteria could be growing in your sinuses and you could get sinusitis, a bacterial infection as well, and then you might need antibiotics. But it's important that people know, like, right, antibiotics don't fix everything. Who hasn't gone? Are you guys our last group? I think. Oh wait, no, I have 2 people. You guys haven't gone. Oh well, Fahim, you were talking so well. What are the dietary instructions that we should tell our patients? Mhm. Yeah, for sure. Because especially if people are coughing really hard, if you just ate a big meal, sometimes you can even vomit. And not that you're sick, like you have a digestive bug, you're just too full. Anybody else have anything to add? No? Okay. Then our last group, number 5, any recommendations the nurse should make for the rest of the family?
Encouraging the vaccinations, watch for worsening symptoms, and keeping a close eye on the
Yes, yes, yeah. Yeah, I think the hand washing is probably like the most important piece there, right? Because we can't like this mom, she's a single parent. She doesn't have another adult who can really help a whole lot, right? Because grandma, I don't know how much she can, and we're trying to protect grandma. Can't really tell the adult to isolate. But we might also say maybe you might consider wearing a mask, and if you're coughing and other things that might be helpful. But yeah, the hand washing is such a big one. I also think about, especially if they're in close quarters, sharing towels as well. you know, whoever's sick, because even if you're washing your hands, like just having whoever is sick have a separate towel for like drying your hands or anything like that, that can help decrease your spread of infection as well. And what? Don't share foods, right? Like it makes sense to me, but I don't know. My husband, every time he gets sick, I'm like, you cannot have any of my drinks because he's so notorious. He'll just drink any of my stuff. I'm like, that's gross. But like, especially when he's sick, I'm like, I don't want any of that. Like, he has been sick the last few weeks, and I have a bottle of water in our bathroom, and I've been hiding it so he doesn't like take little drinks and like get me sick. Okay. Any other questions? You guys did a really good job answering those. Like this case study seems like, oh wow, somebody who is taking care of their mom and their kids, it's not far off of what you guys are gonna see with our patients in our community. And this is the kind of teaching that we're gonna be providing to them when they're sick. And even if you don't work in a clinic where you might see something like this, guess what? When you're a nurse, your friends are gonna call you. They're gonna be like, I'm sick, and they're gonna ask, like, what do I do? So this is really good information to have as you guys are out and you're gonna be leaders in the community for healthcare. All right, so let's jump into respiratory complications, which is another Menti. So you can stay in your groups because after this, we're gonna do our name that patient, or you can go back to your spot of choice, up to you. This one is a lot shorter. Give me a little thumbs up, a like, something so that I know you're here. All right, so we're going to talk about complications in cancer, specifically when we're talking about lower respiratory issues. Next week, we're going to get into the lower respiratory tract. And when we talk about respiratory, we kind of think about neck and up is everything upper respiratory, just kind of what we just covered. Lower respiratory is everything neck below, right? So that really affects the lungs in our breathing. We're going to talk a little bit about the lower respiratory, specifically what complications can happen, and then something about cancer as well. So again, we're going to go not rapid fire, but we're going to be changing to a few topics. We're going to be changing through some of these topics. So we've talked a little bit about pulmonary embolism. And just to remind you guys, oftentimes you'll see this as PE abbreviation. That's a pretty standard medical abbreviation, pulmonary embolism PE. So that's when you have a blood clot that goes into your pulmonary artery, and then it wedges in there, and blood flow can't get to your lungs. It talks about ventilation perfusion mismatch, meaning ventilation, that's the act when you're breathing in and out, the air is moving through your lungs. But the perfusion, the blood flow through, we're not getting blood through our lungs like we should. So even though we're breathing just fine, we're not getting oxygen in our blood, and it's not getting out to our system like it should. So you can have a lung infarction. Just like we talked about the myocardial infarction, a heart attack, you can have part of your lung that actually dies or is damaged from a pulmonary embolism. Here you can see, like, here's where this clot is kind of gotten wedged. And it is up in here, this area, and it's preventing any blood flow getting down to these areas here. And so that's gonna be the area that's damaged from the lungs. So how does it come? Usually it's a deep vein thrombosis that we talked about last week. You know, you can get these and then they travel up the legs most of the time and then go through the heart right to the lungs. You can also have a fat emboli from a fracture. Do you remember what kind of fractures can have that fat emboli that came from one? The long bones, right? So like usually we think femur a lot of the time, they have the fat from the bone marrow that can break into the system. There can also be, thinking about maternal peds, there can be amniotic fluid emboli during labor and delivery. That's something you watch for when you're dealing with moms who are giving birth. So how do we prevent DVTs? That's one of the leading causes of a pulmonary embolism. What do we do to prevent somebody from having a blood clot, a deep vein thrombosis? Compression socks, with the moving, blood thinners. Maybe some belay devices, like probably SCBs or sequential compression devices you often use. Maybe some high cholesterol medication, yeah, that's a good idea. The cholesterol buildup that might add to blood clot formation. So ambulation, right? That's one of our biggest things. Move. I tell my patients, I work per diem, like in either recovery room or like post-surgical. And my biggest instruction I tell patients, I was just telling Amanda this last week, I was like, drink enough water so your pee is clear. Because if you're drinking enough fluid so that you're peeing out clear, that means you're gonna be first really well hydrated, which we want you to be well hydrated. Helps prevent PE or DVTs along with other things. And if you're drinking that much fluid, you're gonna be up going to the bathroom. You gotta go to the bathroom, you're gonna be walking, or if you're Amanda, you're like on her crutches. You know, you're gonna be up and moving. That's getting your blood flow going. That's not only helping prevent a DVT, you're also upright and you're moving around, you're breathing deeper. That helps you to help prevent pneumonia by taking those deeper breaths. So we can keep them really well hydrated. That kind of the fallout from that is there's a lot of benefit to it. What are some signs and symptoms of a PE? Well, a lot of shortness of breath. Generally not swelling so much, but a PE is usually, it's not something that's gradual. It's something that happens usually very fast. That blood clot wedges in that artery and all of a sudden your lung, that area is not getting the blood flow it needs and you have sudden shortness of breath. You are suddenly anxious. Sometimes you can have pink frothy sputum as your body's just trying to get oxygen where it needs to go. I put a lot of these little pictures in your weekly resources. So if you haven't looked at the week resources page, look at those. Sometimes they can help you guys to remember. This one is about pulmonary embolism. He looks kind of, I don't know, he just looks weird. But see how he's kind of blue around his lips? You can start to be cyanotic, so you're not getting the blood flow. He needs oxygen on here. He's got tachycardia. He's got a little tissue with hemoptysis, kind of pumping up some blood. Sudden sharp chest pain. So that's usually what we see with our patients. It's a sudden issue, and it is a medical emergency if somebody has a PE. We don't sit on these people and watch them. We treat them very promptly. So it's sudden onset, trouble breathing, We talked about all of this. So tests to do, usually they're gonna get them right down to a CT scan is probably gonna be our first line of treatment. We wanna see exactly what's going on. We're probably also gonna look and see if there's a D dimer. That's a lab value that tells us about patients if they have clots that are forming. So just like, what's the cardiac marker we look at for heart injury? Troponin, right? Like there's gonna be some key lab value you guys need to know, right? Troponin is key if there's heart injury. What's our key lab value if there's kidney dysfunction? Creatinine. Yeah, remember BUN, it can tell us some, but BUN can be elevated in dehydration as well. So it's that creatinine. For our clotting disorders, if we're thinking about a DVT or a PE, they're going to get a D dimer. If the D dimer is elevated, that's going to tell us that there's some abnormal clotting happening. Angiogram, that might be, right? Or just like, remember, what does the gram mean? It's a picture, and then what do we put into the patient's veins so we can see? It's a contrast dye. You see gram, think contrast dye. So they're gonna do a scan where they inject contrast dye, right? And they're gonna see, does that dye go through all the lungs as well? Or is there a spot where we're not getting the blood flow to go through? Intervention. So what do we do about it? If we identify the blood clot, we're probably they might give them a thrombolytic, which they might go through with a little catheter and inject some medicine to break up the clot. They might give them a general medication that goes through their whole system to break up clots. Now, if that's the case, especially they need to be in ICU because they're higher risk of just bleeding in general. We're probably going to have them on anticoagulants and oxygen. Embolectomy is rare where they go in and just like take out the clot. But a lot of times these patients, they might get a filter placed for pulmonary embolism, meaning that usually it's called an IVC filter or inferior vena cava filter. Because if then we know the main risk factor of PEs is the DVT, breaking loose and coming up, it comes up through our inferior vena cava. So we have these little filters that in usually special procedure lab or interventional radiology, they put them in and they go in through a little catheter and they snake it up through your inferior vena cava and then they deploy it or open it. And it's just like a little mesh umbrella kind of. And it goes through and it kind of fills up your inferior vena cava. The blood flow can go through the mesh just like it should. But it's going to catch any clots that are breaking loose, and then your body will naturally dissolve those clots that are there. That way it prevents them from traveling up to the heart. That makes sense? They can come out. Sometimes they're permanent. Somebody's pretty old. They're like, you know what, you can live with this. Sometimes they'll put them in and then they can go back and take them out later if there's an issue with them as well. So moving on. Pneumothorax. So pneumo, lungs, and then thorax, kind of our chest area. This is where you have a collapsed lung. It doesn't mean the whole lung is collapsed. It might just be partial. So here's a couple of different types. And what we're looking at, the pink here, that is our lung. The blue around it, that's the pleural space. They should be normally right up next to each other. It's kind of like around here. There's a little bit of space there, but it should be pretty close. Here is where you have a well, let's go back. Let's start over here. Pension pneumothorax. Something happened. Well, let's go to traumatic first. I feel like that's easier to understand. So traumatic, we have a knife. We can see that, right? Somebody gets stabbed in the chest. You work in ER, you might see that. If you get stabbed in the chest, you've created a hole in this pleural space. That pleural space is what is expanding and allowing your lungs to then open up, right? So now, and remember, when we breathe in, that's negative pressure, right? We're pulling, like it's kind of like suction almost. We're pulling open our lungs. if we have a knife, something that opens in injury here, then air is gonna get sucked into this pleural space and it pushes our lung closed. Our lungs can't fight against that. Sometimes we can have a tension pneumothorax, and that's where somebody usually has lung disease. I think about our patient with COPD or emphysema. They can have like where their lungs like have trauma to them where they open, like there's damage to the lungs, and then the air leaks outside to that pleural space, and again, pushes the lung closed. Spontaneous pneumothorax, very similar. Thing about spontaneous pneumothorax, actually, I'm gonna put a pin in that. Somebody remind me to come back to spontaneous, okay? All right, so moving on, what do we do about it, right? Because when we have all this pressure or we have all this built up, pushing in on the lungs, we need to relieve that pressure. We can relieve the air, get that air out of this space, right? Because it's not going into the lung, it's just going into the space. Then our lungs can reopen. So this kind of shows somebody with a pneumothorax. There's a couple different things. Thoracentesis, if it's fluid that's built up, if there's pressure there because there's bleeding or some issue, you can actually pull that fluid and that will allow the lungs to open. You might have to put in a chest tube. That's often what we will see. And that tube, it doesn't go into the lung itself, but it goes into this cavity, like the pleural space, and it pulls the air out of that space, allowing the lung to reopen. So when you see chest tubes, no, they don't go into the lungs, they just go into that pleural space that's there. So usually somebody who has a pneumothorax, it's usually a pretty sudden thing. Like it's not like it's slowly ongoing. It's usually they're like, oh, I suddenly have trouble breathing. Whether if it's from knife in their chest or maybe they had ruptured alveoli or something. A lot of times we're going to see asymmetrical chest expansion. So if I go back over here, you know, this person here who has this tension pneumothorax, this side of the chest is probably going to be expanding pretty normally, or this side's not going to be moving as much because the lung isn't really expanding on that side. So one side of their chest is going to be moving abnormally. Oops, excuse me. Dyspnea, chest pain, and then you're not going to be able to hear lung sounds over that affected area, right? Because there's not really air moving in that lung space. They might see some tracheal deviation if that lung is collapsed enough that all that air is in that pleural space. The trachea is actually going to get pushed over. And I think I had to put a picture. Yeah. So this is somebody who's had a pneumothorax, and see how the trachea is kind of pushed over this way a little bit. Because there's extra air in here that's pushing, like this is the trachea right here. And normally it just goes straight down, but here it's kind of curved. So on an x-ray, you might see the trachea kind of pushed over to the side from all the air. Yes, the patient's left side is affected. You can see all the black area is air. And so you can see there's a ton, like they're usually more symmetrical. There's a lot of extra air that's pushed up the lung. So usually, how do we diagnose it, right? We're worried somebody has it. Chest x-ray is going to be what they're going to do first. They might do ultrasound. They might want ABGs, so they really want an x-ray, some sort of imaging to see what's happening. And then they're going to probably do a chest tube, or they might do like a chest drain if this happens in long term, but usually a chest tube is the treatment. You question or just stretching?
Does it only happen to one side of the lungs, or does
It usually just happens on one side. It's one side that has trauma or injury or whatever the issue is. You could have somebody who has, especially if they're like a chronic lung disease person, you know, their lungs are breaking down all over. And if they're end stage, you know, so sick that they're actually having rupture of their lung, it very well could happen on both sides. Usually though, it would happen on this side, and a little bit later, it might happen on this side. They don't usually all happen together. But typically one sided. Well, you certainly wouldn't breathe very well. Yeah, so you'd be heading towards that. Yeah, so, right, and so car accident or trauma, you could have, both sides affected. And that's why we need prompt treatment, because they probably will need chest tube insertion, both sides, or multiple, sometimes depending on where, if it's fluid here and air up here, they might have a couple of chest tubes in. Yeah, they need prompt treatment, just like the PE. Moving on, because similar, talking about trauma, rib fractures, right? How do they happen? Well, car accident, like we were talking about, CPR, right? Anybody who had CPR usually, or if you had CPR done on you, you usually get a rib fracture, right? Or cough, occasionally, especially these little grandmas who have osteoporosis, right? Yeah, they lose the calcium in their bones, they're not as strong, they're coughing hard, and they could actually crack a rib from coughing. In the past, years ago, they used to always wrap your ribs when you had a rib fracture, so it would help put pressure on there and it'd feel a little bit better. But you know what happened to those people that had their ribs wrapped up? They weren't breathing as well and they got pneumonia, right? Because we were putting pressure, it felt real good, but then they weren't breathing very deep. It's like we're in a corset or something real tight. And so then our patients were getting pneumonia and getting more sick. So we were like, oh, okay, guess we're not going to do that. That was very reactionary. Okay, well, if you're in the Menti, can you still see it? Yeah, okay. Well, I think it should come back up in a minute. I think it's just like going to sleep. So it should be waking back up in just a minute. So what do we do typically for a rib fracture? As long as the rib isn't poking out, right? If it's still in the spot it needs to be, we're just going to do kind of care to keep people comfortable, right? We're going to give them pain medicine. We might talk to them about, like, when we say rib fracture, it's not like the rib is like broken off, right? It's just like a crack in the rib. It's painful. We're going to teach them about splinting, which if you've got a rib fracture here, and if you have to cough or sneeze, you might kind of hold that, kind of help give support. We do want to encourage them to have good coughing and breathing, because they're not going to want to breathe as deeply or cough, but they need to help prevent pneumonia. See, that will come up. So flail chest is another complication, and that's where you have multiple rib fractures. It's usually on one side, and it's usually caused from like a crush injury or from a bad car accident, something where somebody gets something very big and heavy that smashes against them. It takes all of their ribs and it just like boom, 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 and they're all smashed in. So normally, when you take a deep breath, we have that negative airflow and we see our chest expand. When we don't have our ribs to help give structure, you can kind of have like a flail chest where it just like, it's like almost pulling in because of that negative pressure. And that's what can happen when we have those multiple rib fractures. With these, if you have a patient with a flail chest, like maybe you respond to a car accident and you're like, oh, wow, they take a breath and this side of their chest is like collapsing in. We always want to make sure we call 911, but we need to make sure, like, we're making sure they can breathe on their own. Sometimes these people can't, like, they're very damaged, so they might need BLS support and then mechanical ventilation when they finally do get to the hospital. So hopefully you guys won't see that very much, but that is interesting at least. Moving on, next one, acute respiratory failure. So when we have people that have acute respiratory failure, it's not people who typically have a chronic respiratory disease. Sometimes people are like, oh yeah, it's like this person has COPD or emphysema or something, so they'll probably get acute respiratory failure. That's not the case. When we say acute respiratory failure, it's usually somebody who's normal, no respiratory dysfunction, and maybe they get the flu. But they have something, like this respiratory failure, it's caused by something else that kind of overwhelms their respiratory system where they're not able to ventilate and breathe on their own. So sometimes it can be COPD, but usually other things, like maybe somebody aspirated, like I think the older people sometimes who aspirates a bunch of things, their lungs just can't tolerate all that's in there. Opioid overdose, right? Our patients who come in and they maybe took whatever it is that was laced with fentanyl, and now they just can't maintain their airway. They can't breathe on their own. So signs and symptoms, they're just not breathing as well, and it's all the signs of not getting the oxygen. They're confused, they're restless, they're maybe having coma. Here's another little picture of this little person. My heart is racing and I can't catch my breath. So we give them oxygen. We try to give them, we're gonna give a bronchodilators to open up their airways. We try to correct the cause, whatever the issue was. If it was infection, we're gonna give them antibiotics. We're gonna do whatever we can help to reverse what happened. And a lot of times, they need intubation and ventilation until we can correct that cause and make it better. We talked about the acute lung injury. Okay, so lung cancer. Moving on. There's a few types of lung cancers, right? Small cell, large cell, adeno, squamous. Not going to ask you about all of those. We're just going to talk about lung cancer in general. So in general, what causes lung cancer? It's smoking, right? 80 to 90% of lung cancer is caused by smoking, which is why it's so important that, we're going to see patients who smoke. So we're going to talk to them about smoking cessation because we know it has such a high risk factor for so many diseases. It also can be other carcinogens, like we think about chemicals, exposure, things like that. Pollution. So usually with lung cancer, people don't have signs and symptoms until it's later stage. The issue with that is when it's later stage, it's usually metastasized or spread to other areas. Sometimes they can have a productive cough. They can get kind of more frequent infections. They might have might be short of breath, especially with exertion. Those are all things that people who are smokers experience as well. So it's really hard to determine. So what we are usually people have like a pleural effusion, or they have something more complicated that happens that finally brings them into the hospital when they get treated. And that's when we find not only the cancer, but it's also metastasized to other areas as well. So we usually do chest x-ray, CT scan. They're probably going to do biopsies, right? And the biopsies are important because that tells you what kind of lung cancer it is. And that lets you know where it probably spread to. Remember, we talked about different types of cancer like to spread to different areas. And so if they can determine what kind of cancer it is, it really helps them to target and look to see where that could have spread to. Here's a picture of like a cross section of a lung, and there's a cancerous growth right in the middle there. So a lot of times these people have chemotherapy and radiation. That's one of our main things that we do for patients with cancer. But these guys might also have red like resections or lobectomies. So a resection of the lung means that like up here, they take out a little piece of that, like the cancered area, they take it out. A lobectomy is where you kind of remove one whole kind of lobe. Remember the lungs, they kind of have those lobes on them. So if they can take out a little piece and sew it back together, essentially, they're going to do as minimal as possible. But if the cancer is much more invasive, they might have to take out that whole lobe. If it has spread through all the lobes on one side, then they might have to take out all of those lobes, right? So it's really important that we know with these patients, if they've had a lobectomy or a resection. I've had patients that have had these before, and you really have more difficulty with like resections. It's more difficult to hear their lung sounds in that area. And they've had a lobectomy. it's really hard to hear over the area where they had the lobectomy. Thoracic surgery, I just want to touch on it. Just know in our chest, we can have a lot of surgeries. We talked some about like cardiac surgeries and stuff last week. With our lungs, you know, they might have any of these. You could even have like lung transplants, right? Some of the big things, right? Anytime we have patients going for surgery, we want to teach them. We want to teach them what to expect, what to bring, what to do, and include family, right? Because the patients, they're not going to remember. They're overwhelmed and usually they get medications. A lot of times after thoracic surgery, these patients come out with chest tubes. So it's important that a lot of times we tell them, right? Be prepared to have maybe a tube coming out of your chest. You wake up with that, first of all, it's really freaky. You're like, what is happening? And it helps to kind of give more knowledge to the patients. They're less confused, less stressed. All right. Oh yeah, I forgot about this. So cue recognition. The patient comes back from a follow-up visit to his healthcare and he said his new inhaler doesn't help him. What do you do? So turn to your friend or turn to your peers and just say, hey, what do you do if your patient has a new inhaler? They said it doesn't work. All right, what do we do? Yeah, show me how you use it. So I clicked off again. This, I don't know if you guys ever seen the show House. But this kind of demonstrated it so beautifully.
My asthma. They said they'd fix it, but it didn't make any difference at all.
Well, sometimes doctors make mistakes. And you need to try twice as hard to fix it. You're using your inhaler?
All the time, go through one a week.
You sure you're using it right?
Do I look like an idiot?
No. Why don't you show me how your inhaler works?
Okay, right? And so sometimes if we don't ask for that return demonstration, right? She's like, yeah, she doesn't look like an idiot, right? She looks smart, she looks capable. But if there's been a breakdown, we could easily have patients who think they're inhaler, like this is how to use it, right? So it's really important that we know how patients are using their medications or how they're taking it. There's like old stories of patients who were prescribed suppositories, right? The suppositories are usually wrapped in like a foil packet. And they're like, man, it's still not working. I'm like, well, how did you take it? And they're like, with water. Like they would swallow them, right? Like, so it's just so important that we ask people and make sure they know about their medication, how to use it. And I don't want to do this either. How about we take another break? Yeah. Okay, we can do that. You guys can do these later if you want to. Let's come back at about 5 till. And we're gonna do another group. We're gonna do name that patient. So when you come back, we're gonna come to our groups.